It is a huge, huge, huge honor for me to be podcast interviewing Raquel Zita Gomes, who is a legend on Facebook with all of her implant postings. I mean, you're a dentist and artist. You were born in 1977 in Portugal, and since you were a little girl, you wanted to be a doctor, but you also love the arts. So the area she chose was to combine science and art was dentistry. Raquel is a graduate dental medicine doctor from Faculty of Dental Medicine of the University of Oporto with a master's degree in implantology by the same faculty. She did a postgraduate in implantology at Bränemark Institute in Sweden and a specialization course in implantology at FMDUP. Currently, she is undergoing the last year of PhD program in implantology and FMDUP. She has 2 private practices in Portugal and works exclusively in implantology and advanced oral surgery. She also does research work in the fields of biomaterials and implants. She is a member of Megagen International Network of Continuous Education and an opinion leader of Megagen Portugal. In her curriculum, she has several publications in peer-reviewed journals, international conferences and workshops. She has several merit and honor professional awards in her career. I mean, when I look at your cases, I mean, they even call you the dental diva.
You are kind. You are so kind. No, I work a lot. I have passion for what I do, and I think that's why everyone is noticing my work. I love dentistry. I love surgery, and I'm passionate about my profession. I think it shows.
It shows that you're really painting an oil painting, but just happen to be using implants and porcelain and blood. I mean, it's really, you absolutely married art with surgery, didn't you?
I love art. I did ballet, I did piano, I did theater when I was younger, and I love medicine, and surgery is my passion, and I love everything that is linked to implantology and bone regeneration and oral surgery. I try to be a step forward every time, and I try to improve every day, and I think that's why I am trying to do some different work with some different techniques.
Wow. So what advice would you give on implantology? How do you become a better implantologist?
You have to work a lot. You have to work a lot. You have to study a lot, because things don't fall up from the sky, and you have to deliver and be compromised with dentistry every day, and you have to be engaged with dentistry, because otherwise it's not possible to get better every day.
So what are the new trends in modern implantology today? You talk a lot about implant stability quotient measurements.
Yes.
Talk about that.
It's one of my areas of research, because I do a lot of research with implant stability quotient, ISQ, and the correlation between ISQ, torque, and even the bone density that we can measure in CBCT, in House-Fields unit, and we can correlate all the 3 things. And we even can extrapolate some equations and calculate one things from the others. And I do a lot of research with comparing different kind of bone generations and different types of rehabilitations, and comparing all the follow-ups with ISQ and torque and CBCT. It's one of my interest areas in dentistry and in implantology.
The patient, we always say, the patient doesn't tell the dentist what to do, but it's a tough conversation. They want immediate placement. They want to place the implant, have the tooth, and walk out. When is that a good idea, and when is that a bad idea?
Well, when I have guidelines with ISQ, I do my procedures very predictably, because normally in a single implant, for instance, if I have the torque less than 45 Newton centimeter and ISQ less than 60, I normally put the cover screw. But if I have the torque more than 45 Newton centimeter and the ISQ between 60 and 70, I can put the healing abutment without no problem. And if I have the 45 Newton centimeter of torque and the ISQ above 72, I can do an immediate loading without no problem. And people today, they search in the internet, they see everything, they ask everything, they want everything today we have to explain the patient that to do some guidelines and to do work that we can be predictable, we have to have some kind of values to achieve. Otherwise, it's a little bit not objective to do the immediate loading. So normally I always measure the ISQ and the torque. For single implants, this is the guidelines. Of course, if we have multiple implants, we can fertilize, we can do cross arch, and the values can be a little bit low. But otherwise, we shouldn't do immediate loading without this kind of requisites.
So you CBCT, when I got out of school, you know, that wasn't there. It was just a pano machine. It was 2D when I got out of school in '87. CBCT's really been a game changer, hasn't it?
Yes. A few years ago, I was working with the OPG and the traditional CT scan. Now I have CBCT on my office, and it's much more easy because we can do the CBCT. We can measure the Hounsfield's units. We can measure the bone density. We can predict the implant, the place. We can do everything. Today, the dentistry is so advanced with the new technologies, with softwares, with the digital workflows. We can do miracles. And with this kind of techniques, we do the miracles, but with objective measures, and we can predict the results, and we can guarantee to the patient that we are doing the things the best way possible.
That's so funny that you're using the word miracles. You know, I grew up in Kansas, and my first international trip was actually to your country, Portugal.
Portugal, really?
Yeah, because I went to Bishop Carroll, and they had this racket going where every year they would rent a 747 and fill it up with about 450 Catholic high school boys, and they would fly them to Lisbon, Portugal, and we go up to Fatima where they have the miracle water. That's what made me think about that. And we stayed in a seminary, and the reason they did this whole trip and paid for the whole thing was because every year about 10 boys would cancel their return flight home and stay there and become a priest. So it was a great return on investment for them. It was, the lead was just get Catholic high school boys and then fly them to Fatima. But I was 16 years old, so I was born in '62, so whatever that was. And my God, that was the most fun trip of high school you could imagine, going with 450 guys to Portugal. But man, what a beautiful country. And so I was wondering, do you ever use the miracle water from Fatima to mix with your bone grafting?
Sometimes I pray. I do the cross and I pray. Because when we try to do so many miracles at the same time, to put the implant, to do the bone regeneration, to do immediate loading, to do everything at once, sometimes it's a little bit more complicated and we have to pray sometimes.
So you're a big fan of Megagen. Talk about that. Why are you a big fan of Megagen? Last time I went to the IDF meeting in Cologne, I think there were 175 different implant companies there. Why did you pick that one as opposed to all the other ones?
Well, I started with Noble BioCare like 14 years ago, and I use it for a long time. And after some times, when I was presented to Megagen, to the implant I'm researching, that is the any-ridge implant, that is a completely different implant. It's like a losangle. It's a paradigm shifting. It's completely, we have to shift our mind to see the things in a different perspective, because the implant gives much more primary stability, and because the neck is so straight, we don't have compression of the bone, we don't have resorption of the cortical, because the strength of the implant is focused on the medular bone. So we have like a tree, like the roots of a tree, and we have the strength concentrated in the medular and not in the cortical. So it's completely different. At the beginning, I thought the implant was very strange, and I'm very skeptic about some things. And I went to the European scientific meeting of Megagen to see what they were showing me, because I was feeling this is so strange. But at the same time, I was seeing so different characteristics that I told to myself, why not? Let's research, let's see. And I was very admired with the characteristics. And then I started a project with Megagen Portugal, and to do some education programs, and I'm doing the PhD also with the any-ridge implants. And I started to do some research, and I comproved what was my clinical sense, that the implant was really different from the others. And it's outstanding the kind of things that we can do with that implant. And of course we have a learning curve with the system, of course, because every system we have it, but the implant is really different, and for me it's the best implant I ever worked till now. So I was convinced, and I did a lot of research, and research comproved my clinical sense. And I started to work with Megagen Portugal and Megagen International, because they have a big network of connections around the world, and people share not only the good things but also the bad things, and we try to have the best product and to improve the products. So they do a lot of multicentric studies between countries with very experienced doctors, and we try to improve the products. So it's a company that is run by a periodontologist. You know Dr. Juan Bränemark, you already interviewed him. He's an outstanding man, and he has a vision not commercial. You understand? He's very clinical. He's a periodontologist, and he thinks biologically. I think that's the best characteristic of any-ridge from Megagen. The implant was thought for someone that has the biological principles, and it works very well in the clinic.
He is an amazing man.
Yeah,
and
he's
now,
very small, but he's very big. He's small in size, but he's a wonderful person, and he gives a lot of support to young dentists that are doing research and clinical trials. So Megagen is a company that I feel very comfortable, and that supports a lot the new generation of implantologists and the new generation of researchers.
and how do you say his name? Park Kwong Bum?
Kwam Boom Pak.
Kwam Boom Park?
Pak, yes.
Yeah, he's the most humble man, and I think that's why he's so successful, because he listened to his patients, he listened to the other dentists, he listens to everybody, and you see him in those meetings with all these rock star implantologists, and he's just taking it all in, real quiet, writing notes. I mean, he's an amazing man. And now they just got married with Straumann. Straumann invested heavily in the Megagen out of Switzerland.
Yes, they are doing a partnership, because I think Straumann was having some trouble with the market, and Megagen is raising a new market, namely in Asia, and I think Straumann did a good partnership with Megagen because they are win-to-win situation between the two, I think.
And would you say that one is a Straumann is a more high cost implant and Megagen was a more mid cost?
Yes, probably. In Portugal, yes. I don't know around the world, but I think it's the same. Straumann is a more old brand that is more stabilized in the market, and the prices are a little bit higher. And Megagen, to start, for instance, in Portugal, they started with a medium price because otherwise they wouldn't have a chance to have a market. So they started with a medium value, and I think they have a very high quality product for the price.
But you really like the I mean Megagen sells a lot of different implants, but you really like
No, I only use the AnyRidge.
The AnyRidge.
Yes, because the other implants, let's be realistic, they are copies of other systems. They have Straumann, they have Bränemark, they have all the traditional implants. But AnyRidge is the gold of Megagen. It's the product that they developed from the beginning. It's the implant that is so different, and it has so different characteristics, and I think is the implant that most of the researchers around the world are working with Megagen are using AnyRidge.
So, what do they have to learn about guided bone regeneration? How often do you use that? How important is that?
Well, I use it a lot because nowadays the cases normally, when you have referees from other colleagues, normally they referee the difficult cases, not the easy ones. The easy ones, they do it. So normally, I think more than 50% of the cases you have to do guided bone generations simultaneously or prior or concomitant to implants. And we have a lot of techniques, and techniques are very innovative. For instance, AnyRidge and Megagen have the iGen, that is a titanium mesh that is fixed to implants. So it's an innovative concept that is very useful because you don't have to fix it with other pins or screws. You use the implant to fix the membrane, for instance. So we have a lot today, a lot of techniques, a lot of products that take our daily practice more easier, because a few years ago we have to do some complicated procedures, and now with these new techniques sometimes we can avoid some big procedures, some big surgeries, because with these new techniques we are simplifying dentistry.
That is amazing. Now, do you also do plasma-rich platelets?
Yes, I use plasma-rich fibrin. 12 years ago, I started with the NA2 protocol that was from BTI. But the system was a little bit sensitive to the technique, the activation, and a few years after, I don't know, I think it passed the trend. Now I'm using the choker method, and I think it's much more easier because you don't have to activate anything. He uses biology, and it works with the times of coagulation and APRF and IPRF. I use it a lot, and it simplifies and it stimulates the healing. And Professor Joseph Stokrum is an amazing man, and I met him personally in Russia in the Megagen meeting, the international meeting, and also in Portugal. He came 2 or 3 weeks ago here to Portugal, and he's always improving. He's always thinking about something to improve the guided bone generation. He uses plasma for everything, since periodontal surgery, since guideboard regeneration, sinus lift, lateralization. He is always improving, always researching, always having something different, something more. So he's an amazing man, and the method is very simple to use, and I use it on a daily basis, yes.
So a month ago, 5,000 brand new dentists graduated in just the United States alone, and most all of them say they didn't get any implant training, they didn't place one single implant, and now they're listening to someone like you who's a rock star. How do they go from, I just came out of school, I've never placed one, and you've been doing this for over a decade, and you've mastered it. How would they get from graduation to where you're at?
Well, I also, when I graduate, I never put an implant. All of my training was after graduation. I was very passionate about implantology, and I started very early to seek for education. And I went alone to Sweden, and I did some post-graduation courses, and I started with the simple cases. And then after a few years, I felt that I wasn't prepared for the kind of cases that I was trying to do, and I had to do something more, and I tried to do, and I did the specialization in full time, and then the master degree. I'm always trying to learn new things, new techniques, because nowadays the cases that sometimes we have from referees, colleagues, are so difficult, so complex, and we have to have training. And then I started the PhD. I do a lot of research. I work a lot with Megagen and in research work, and in sometimes when I feel that I have some technique that I want to improve, I go abroad. I go to South Africa. I went to Howard Gluckman, that is an amazing man, to learn some techniques. I went to Brazil to learn lateralization, because when you are in a step that you're already doing a lot of implantology, some strange cases and some difficult cases are going to happen, and you have to be prepared to solve it. So you have to be very well educated and very well trained, and sometimes you have to go and do some private courses and also the education programs in universities in full time, because you have to have training. Otherwise, it's difficult to master the technique.
We were joking about using miracle water from Fatima in your bone grafting, but I want to ask you a religious question. Do you think that dentists religiously worship the enamel, and that's killing the 3-unit bridge? When sometimes I'll see a disastrous where someone will do a sinus lift. And the point being is, do you think dentists worship the enamel because they don't want to prepare 2 teeth, but they have no problem drilling through the gum, through the bone, packing the sinus with mesh and titanium and GBR and PRP and all this stuff? Do you sometimes think that maybe the pendulum has swung too far? Because if you talk to a sinus doctor or a rhinologist, a lot of times they'll say things like, you have no respect for the sinus because you're a dentist. So the sinus doctors say, shave down the teeth. And the dentists say, no, shave down the sinus. Can you objectively, do you think the pendulum's in the middle? Because some kids come out of school and they feel like their peers, that if they file down 2 teeth and do a bridge, their peers are going to say, dude, you're a hack. But maybe their brother's ENT doctor and saying, stay out of my sinus. Do you think there's a moderation there, or do you think dentists are just biased towards enamel?
I think it's a little bit biased. Of course, we always think of the treatment plan because we have a certain education. If we have implantology or oral surgery education, we are going to think in a way. If we have oral rehabilitation or dentistry, general dentist, we are going to think another way. I think sometimes people are very extreme. I think we are dentists and we have to see the patient as a whole and as a person. And sometimes we complicate a lot. So sometimes I do bridges. It's not my first option in most of the cases, but sometimes it's the best option for the patient. We have to think about the balance, about the time, about the complications, about the type of patient that we have. So sometimes it's preferable to do a bridge than a very complicated sinus to do an implant. For instance, for me, it's my humble opinion, but sometimes we have to see the patient as a dentist. We have to be, at the beginning, a general dentist to do the diagnostic. And then afterwards, we can use all the techniques, all the skills that we have in implantology or wherever, but I think we have to think that the patient could be our father, our mother, our daughter, whatever. So sometimes it's a little bit to one side, so with moderation.
And I want to talk about the other end, failure. It looks like it's kind of interesting how I don't believe dentistry has defined what a failure is, because you see a lot of implants where it doesn't matter how much bone loss or PeriImplantitis around it, if that implant's still solid and the patient can still eat a sandwich,
sometimes it's there.
It still goes. So where do you draw a quantified line of saying, no, this implant is failed? It's got, even though the patient's saying, I don't feel a thing and I can go eat a pizza.
Yes, sometimes it's difficult because sometimes the patient doesn't feel anything and doesn't have any complaints, but we see the x-ray and oh my God, what is this? So normally I think it's multifactorial, and we have to take in account several factors to see if the implant is failed or not, because normally when the implant has more than 50% of bone loss, we have to think if it should be there or not. Of course, it has an acute infection. The gum is always swelling. That's an indication for explant the implant, to take it off. But if it has the same amount of bone loss and the gum is healthy, the biotype is thick, the patient doesn't have any complaint, let's wait. Let's see the biology. So I'm not so fundamentalist. I think each case is a case, and we have to think about all the considerations, all the factors. And then in each patient, we should decide, should I take off the implant or should I maintain and control?
Okay, so I want to focus this on the young kids who just walked out of school a month ago, who've never placed an implant. You're saying you like the AnyRidge system by Megagen. Now I want you to talk about what is an easy case. When they're looking at the supply of patients that's in their office where they're working, whatever, what would be some real low-hanging fruit, easy cases to start? And then talk about the other end. What would be a disaster of saying, no, that's an advanced case that would even challenge you?
Well, I think what is easy or difficult, it depends on education. But we are talking of someone that never put an implant and are graduating at this moment. An easy case will be like a single implant with all the bone healed, with a space, with a good open of the mouth, everything. The patient is not very anxious. The patient will collaborate. The patient don't have any kind of healthy problems. The patient doesn't smoke. There are so many factors, but if we have an ideal case, we have a healthy patient, a male, that the bone is better, no smoker, single implant with a good opening of the mouth will be an easy case. The difficult case, the things that you shouldn't start to do the first time you are leaving the dentist school should be a sinus lift or a lateralization of the nerve or a bone block. This is kind of procedure that even for people that are very trained and very skilled, sometimes they have some consequences and they have some problems. So you should stay for the basic, and then after doing a lot of basic cases, you should start to improve and try to do some more advanced cases. But I think we have a scale, and we should respect the cases that you shouldn't do anything, because sometimes when you do it and do it wrong, sometimes it's worse than not doing anything.
But what specific tooth structure, tooth numbers, and anatomical areas would you stay away from?
Sometimes in the posterior, when we have very low-high length, you should avoid, because we have the mental, the alveolar nerve, and we can do some injuries. Here in the anterior, normally it's easier, but the bone is very more dense, so you have to be very precise in your hand. Sometimes the upper jaw in the anterior zone are tricky, because sometimes they look very easy, because in terms of access they are easy, but sometimes they are very tricky, because in the anterior zone, if you put the implant in a incorrect position, more vestibular, it can be a disaster if the patient has a high smile and shows a lot of gum. So it depends on the case. And if you have the sinus that is very pneumatized, stay away from the sinus, because sometimes when the implant goes to the sinus and creates sinusitis, chronic sinusitis, and sometimes you have to open to go get the implant, sometimes it's very complicated. So stay away from the cases that are limits. Start with the case that you have a lot of bone, like 20 millimeters, to put an implant of 13 or 15 without no problem, and control all the angulation, control with X-rays, even in the operation, and be sure that your skills and your education permits to do this kind of procedures. Otherwise, it's better to not to do it and to send to everyone, to other people that are more prepared.
What % of your implants do you use a surgical guide for?
Normally, I don't use a lot of surgical guides. I have to be very honest, because nowadays I'm doing implantology for 14 years. And I think the best guide is to drill and to close the mouth and to see the inclinations and the angulations, and to, of course, the guide will help. I don't have any question. And sometimes when I do immediate loading, then I have the crown or the prosthesis already with the skeleton made. I use it as a try-in. So I put the drill and I see if it's in the correct position. But normally I don't use. I use a lot some rules to measure, and I use the lines of the face, the lines of the canines. I have some tricks to orientate my implants, and I normally don't use 4 system the guides. But I think in the future that it should be the way, because everything is turning digital, everything is computerized. But sometimes even the surgeries without opening the flap to work without seeing. For my kind of education, is a little bit tricky. I think the flapless surgeries are for people that are very prepared and they have eyes in the fingers. So I think companies sometimes sell the guided surgery for those that are starting to see this is very easy, we do all the programmation, you only to put the implants, but be careful because sometimes it's more difficult to work with a guide without opening a flap than raising a flap and seeing exactly where are you working and to see the limits of the bone and to feel the characteristic of the density of the bone, because someone that is not very experienced, it will be a little bit tricky.
What continuing education courses do you like to learn how to place implants? If someone listening to you wanted to get more education, what would you recommend?
There's a lot of good education programs. Of course, it depends on what the doctor wants. If the doctor wants something that is official, it should be on the university with full time or at least part time in 2 or 3 years to have some training, to have some education, some programs, some contacts with the patients. But of course, there are lots of private courses around the world in the internet. Today, everything is everywhere. So sometimes we even I think people are a little bit confused with so many offering of courses and online and everywhere in the world. But I think if someone wants to do a certain area of dentistry in a more exclusive way, it should be first in a university, some training of at least part-time, 2 or 3 years. And then if the people want to have some education specific, there are lots of courses, 1 week, 3 days, education programs, internet. We have a lot of sharing knowledge today.
So that you're just a wealth of information. One of the problems that these young dentists see is they see patients coming in with PeriImplantitis. A lot of hygienists listen to this show. They have patients with PeriImplantitis. Do you have any? How do you treat PeriImplantitis? Are there any things you like? And you hear people talking. Some go around it with a laser. Some use mouthwashes. You know, how do you treat PeriImplantitis?
Well, normally it starts with the basic good hygiene and good periodontal treatment, good status periodontal, and then after that, most of the cases we have to do surgical. So we have to open, we have to clean. I use a lot of topic antibiotics. I use plasma a lot, biomaterials, sometimes autogenous bone. It depends on the case, and it depends on the amount of bone loss. But today we have a lot of techniques that are very proved that they work. I don't have experience with the laser in surgical field. I have experience with low laser level therapy that I use a lot, but for other reasons. But the laser is proved that it decontaminates very well the area. Sometimes I also use some citric acid from the endodontics. Normally they use it for decontaminate the surface of the implants, and I use topic antibiotics. I use everything in my hand because sometimes it's very difficult to stop a PeriImplantitis, and even with the treatment, with the surgical treatment, sometimes it doesn't work.
You know, it's when you look at online CE or you go to these implant symposiums, it's always full mouth, reconstruction. Yet when you look at the data, 94 to 96% of all crowns and implants are placed one at a time. When you're looking at a one implant at a time, the most common question young dentists have is, should I cement the final restoration on, or should I screw it on?
Screw. It's funny because 2 hours ago I was lecturing in a study club, and we are debating about cemented versus screwed retain. And some countries, they have more tradition on cemented, and some countries have more tradition on screwed. But in my opinion, and for the literature that I've been revising, and for my education, it's always preferable to do screw retained. Because if you have a problem, it's easy to take off the crown, to clean, to do the surgical procedure, and then to put the crown again. If it's cemented, sometimes with the final cement, you can't take off the crown. And if you have problems, sometimes you have to, with a burr, you have to take off and lose the crown. So I prefer to do screw retained. But sometimes it's not possible because of the angulations. But nowadays, with the angled abutments and everything in the market, when it's possible, and normally I do screw retain, and even the whole of the screw. Today with opaque composites, we can and Teflon underneath, we can also not seeing the hole, and the people are not open the mouth and see, look, it's here. So I prefer the screw retain, but I think it's a kind of trend. I think some people like the cemented, and cement sometimes they have some excess underneath the gum, and sometimes they do PeriImplantitis with the rest of cement. So I prefer always screw retain, but sometimes it's not possible, and I do the cemented, but normally screw retain.
So then, what did you think? It was in the news this week. DENTSPLY Sirona just bought MIS implants out of Israel. MIS standing for Made It Simple. What did you think of that strategy? Do you think that was the same strategy as Straumann investing in Megagen, a high cost with a low cost?
Probably. I think the future, because the big brands are losing some market, it's natural, because a few years ago we had, I don't know, hundreds of implants brands. Now we have probably thousands. So it's normally that the market will grow, but it's sharing. So it's normal that the big companies that are losing some market will associate with the companies that are raising and having new markets, namely in Asia. And it's normal, this kind of cooperation. And I think it's good for both of companies.
Well, that's my lead up to my next question, because, in many markets, like, say, cars, you have a premium car,
Mm-hmm.
and then you have a more low-cost value car. And when implants started with Bränemark, they were only taught to oral surgeons. They were very expensive. And now you've seen in the last 10 years these mid-price value brands come out. But the patients the dentists that you're talking to right now, America is a big country, and there's a lot
Mm-hmm.
more middle class than there is rich. And so grandma comes in, and she's got a denture, and she doesn't have a lot of money, and she's retired, and she's living paycheck to paycheck. So
Yeah.
a lot of them are tempted to put a couple of mini implants down there, to have the dentures snap down on them. What do you think of the very low cost market, mini implants for grandma's denture? What do you do? What do you do when grandma comes in, doesn't have a lot of money, but she's having a hard time eating with her denture and can't afford, all on four? All on four in the United States, they only do about 18,000 arches a year in the United States out of 330 million people. So that's not even around here.
In Portugal, we do a lot, because probably the market is not so good as in the United States. And in Portugal, we have a lot of market to do the hybrid. We call it hybrid all-on-4. It's not ceramic, it's acrylic, it's metal acrylic, and normally at least for lower jaw we use 4. In the upper jaw, I prefer 6, but sometimes when we have good conditions, we also do all-on-4. And in patients that are very elder, and they don't have many possibilities of money, sometimes we do some locators, and it's very easy. They take off, they clean, and it's functional for this kind of, because they don't have many shearing force. So for someone that is 85 years old and does use a removal procedures for 50 years, so to do 2 locators is not perfect, but it will be okay for this kind of situation. I don't do a lot of this kind of rehabilitations, but in Portugal we do a lot of all-on-4. I have more cases probably with metal acrylic than in metal ceramic, because metal ceramic is very expensive here in Portugal for the salaries, the medium salaries. So and in Portugal we don't have a public service. We only have private. So it's difficult because Portugal is not so healthy country. So sometimes we have to do the type of rehabilitation that is feasible for that kind of patient.
Now, the all-on-4 was actually invented in Portugal
Yes,
by
Paulo
Melo.
Yeah.
Paulo Melo, is he in Lisbon?
Yes, he's in Lisbon, but
Where are you?
I'm in Porto. I'm more in the north.
You're more in the north. Are you closer to Fatima?
Fatima is more or less in the middle.
So, have you worked with Paulo Melo?
Not work with him, but I know him, and he's a very well-known name around the world. He has clinics all around the world, and he invented the concept, and he's a very smart guy. And in business, he's amazing. He's very successful. He has clinics all over the world, and I really admire that ability for business that he has. And he invented, and he has some patents of even from Noble Biocare, Speedy, and some concepts. And I know him, but I never worked with him. But I respect a lot what he achieved.
Yeah, so that's an amazing concept. So you're not a big fan of minis then?
What? Beg your pardon?
So you said you don't do a lot of mini implants, a lot of locators.
No, I don't. I don't, because the type of clients that I have, the type of referees, normally people, when they pay implants, they normally want a fixed rehabilitation. And because with the locators, they have to take it off to do the hygiene. Sometimes people are not so friendly about this kind of procedures. But in elderly people, sometimes I use, because it's easier for them to take off the denture and to clean, because all-on-4 in people that don't have hygiene, it's complicated because a lot of PeriImplantitis, and it's difficult to do the daily hygiene.
You know, when you do a root canal, if it fails real quick, it was because when the root canal was done, it wasn't cleaned out and debrided thoroughly. But if it works for 3 or 4 or 5 years, then fails, it's probably from the restoration. So my question is, when implants fail, do they tend to fail fast and out of the gate, or do they tend to fail long and 5 or 10 years later?
Well, we have two kinds of failures. We have the immediate failures, but nowadays with new techniques, and if you are using a system that you know well and you work with the guidelines, normally they don't fail a lot. The failures are very low. But I'm deparing with a new situation that are cases that are rehabilitated for about 10 to 12 years ago, and they started to fail. And people normally, they pay, they say, okay, I have the fixed rehabilitation, I don't have to take care, and they do everything, and they don't do the controls, they don't go to the dentist to check out everything, and sometimes after 10 years everything comes off. And the new generation of implantology are dealing with a lot of these cases, at least here in Portugal. Failures for cases about 10 years. And sometimes the patient comes with the prostheses and the implants in the hand. I don't know if it's the time of the rehabilitation, or if it's the lack of hygiene or the lack of controls, because sometimes people think, I paid and this is done and this is for life, but nothing is eternal. So people have to have conscience that they have to do the maintenance with the professionals and daily, otherwise this will fail and the implants will fail. People have to be aware of that.
So that's my point. If that's the case, 10 years later, they have these implants, are not taking care of them. Do you think full mouth implants that are removable are more compliant, easy for the patient to brush and clean than full mouth implants that are fixed? If you had someone, these people lost all their teeth. I mean, I'm not going to lose all my teeth. You're not going to lose all your teeth because we brush, floss, we have home care. So the people that end up losing all their teeth, usually they already showed that they don't really take care of their teeth. Yeah. So if you have someone who's lost all their teeth, isn't everything you just said make more sense? That we do a fixed removable, that we do implants with a removable case, as opposed to implants that are fixed and they can't come out?
Yes, I think if this kind of rehabilitation will fail, it's better to take other option. Otherwise, it will happen again. In these cases, I have some cases that did the implants some few years ago, and they are failing. And in some cases, I prefer to do an overdenture because people take off and they clean. Because otherwise, I think in a few years it will be the same. Because people, it's difficult to change mentalities. It's difficult to create in the minds of people that they have to do the maintenance every day. Because otherwise, the teeth will lost or the implants will lost. Because it is the same. If people don't brush, don't do anything, don't do controls, don't do the normal visiting to the dentist, of course the things will happen and people will lose the implants. So people have to be aware, and I think sometimes we have to spend a little bit more time to teach the people to take care of the implants or the teeth or the rehabilitation, because otherwise in a few years they will lose everything.
But you could teach them how to quit smoking and quit drinking and quit overeating, and 10 years later they're still smoking, drinking, and they're overweight.
It's complicated.
It's very complicated, but it just seems to me that, especially as they get older, it just seems to me it's so much easier for them to take it out and brush it in the sink and then brush their implants and snap it back in.
And sometimes they are even not at home. They are in foster homes. And sometimes there are other people that are doing the hygiene for them. So it's easier in these cases of elderly people to take off and to do the cleaning with the process outside the mouth, and it will work well. Because they don't have so many masticatory forces, and it will, if they do the maintenance and they will do the maintenance of the locators or whatever, it will work well.
I want to go back to economics. I only got you for 5 more minutes. You said earlier that there wasn't that most dentistry. There's 10 million people in Portugal about.
Yes.
And how many dentists? 10 million.
8,000.
Okay, so you got 10 million people, and you got 8,000 dentists, but the dentistry is not paid by the government, and it's not paid for by your employer, right? So there's basically, how much dental insurance is in Portugal?
There aren't so many, because the insurance here are not very good, because, of course, if it's only private, the insurance companies don't want to lose money. So it's complicated, because it's not so good, the insurance here in Portugal. People pay a lot and don't have, because some treatments are not included, you know. Of course, some public workers have some help from the government, but they aren't all. Or, for instance, people that work in a bank, they have an insurance that is only for people that work in a bank, but normally they don't have many support. So it's not very easy, and that's why Portugal has oral health that is not very good.
Well, the reason I'm asking is because you're being listened to right now in 146 countries, and so many people, when they're in their country, they blame all their problems on the local insurance. And then you go to like Singapore, and there is no dental insurance. And then you go across, in Portugal there's not, but then you go jump across Portugal and into England, where the NHS pays $100 for a root canal, and they don't realize that 5,000 dentists in England said, forget it, I'm not even going to play that game. So I guess the point I'm making is, you speak Portuguese, so you're probably very familiar with Brazil. I think there's 20 people speaking Portuguese in Brazil for every one in Portugal. They don't have dental insurance there. So
but the mentality is completely different. They are very careful with the teeth and with aesthetics, and they are. In Brazil, they are very, very careful with that. It's not the same in Portugal. People are not so careful about it. In Brazil, it's amazing. They don't have money to eat, but they have money to put the teeth in healthy and with orthodontics. It's a kind of mentality, I think.
So you're saying Brazil is more aesthetically driven. People in Brazil are more into beauty and aesthetics. Yeah. The largest lecture I ever gave in my life was in São Paulo, Brazil. It was 4,000 dentists. And I've never seen a country of people who are more into beauty and taking it more serious. And you're right. Girls in Brazil would spend their money on lipstick before they bought anything else. Would you agree?
Yes, I agree totally.
Oh, yeah. And my God, they would spend all their money on makeup and lipstick and aesthetics before, anything else. It is. But in saying that, when I got out of school, in 87, 30 years ago, there wasn't really PPOs or these discount plans. And now 82% of the dentists in the United States take these discount plans. And a lot of people think, well, there's nothing you can do because that's the way it is. And I always remind them, well, 50% of Americans don't have any form of dental insurance. And there's no such thing as dental insurance in Portugal, Brazil, Singapore. And when you go to a Singapore dentist and they say, well, how do they buy a crown? And they say, well, the same way an American buys an iPhone.
Yes.
I mean, when you need an iPhone.
It's a mentality.
Yeah, it is. It's totally
it's a priorities.
Yeah, it's totally a tradition, a culture, a mentality, and a lot of beliefs. You just have to believe in it. And if you believe that a patient is not going to spend any money on themselves and they're only going to do whatever the NHS pays for in London, then fine, go get $100 root canal. But do you want $100 root canal, or would you rather go to the United States and get $1,000 root canal, or go to Portugal where you're pricing a root canal so that you're making money on it? You know,
Yeah.
and then here's Japan. You go to Japan, it's the same thing. I mean, they basically pay almost no money for a root canal. I mean, it's basically $100. And it's like, here's one of the most advanced societies on earth, with trains, high-speed trains, all the fancy factories. I mean, Japan is one of the cleanest, richest countries in the world. But then when you switch over to dentistry, they're all just like, well, whatever the government pays for. You know what I mean?
Yeah.
It's just a very complex mentality.
It's. I think it's the culture. I think it's the education. I think it's priorities. It depends on the culture. It depends on the country. There are so many factors.
Well, that was an hour. I can't believe that was an hour. That was the fastest hour I've ever
So,
done. I'm gonna start begging to you now. I'm gonna beg to you because we started Dental Town in 1998, and now there's 217,000 dentists on it. And then the iPhone came out in 2008, so we started the app, and now the app has 50,000 of those 217,000 dentists. But on the app and the PC, in 2006, we started the online CE. We've only put up 350 courses, but they've been viewed over 600,000 times, and from every country on earth. And I would fly all the way to Portugal to get a course out of you. It just would be so amazing. I mean, I see your work. I see your work on your Facebook page. What is your Facebook page? It's just facebook.com/
No, it's I always put my work in Follow the Red. Because yeah, Follow the Red, the group. Because Delia started the Follow the Pink, and it was a success, a big success. And then afterward, Morvarit Keshvari started the Follow the White. And I was joking with them, publishing some cases of blood, of surgery, and I started to put Follow the Red. And they were amazing with me and told me and incentivized me, please create Follow the Red, because there are no group of surgery open to share the knowledge, to share experience. And really it was an amazing experience, because I started Follow the Red in January, this January, so 6 months ago, and I have 12,500 followers. So it's like I was so amazed with all the people that were interested in the surgery, in sharing, in seeing, and it's getting bigger and bigger. And also I have to thank Delia, because she's an amazing woman. She's an amazing person and an amazing doctor, and she's so driven, so passionate, and she's starting new projects about women in dentistry, divas in dentistry, and it's amazing the kind of recognizing that we are having, because I was really amazed with that. But I have to thank Delia and Morvarit and Cleopatra, because she's also in the group, and she's amazing. I think yes, from Greece.
And Delia was born in Romania?
In Romania, and then she's in the United States, I think, for 10 years or something. And
did you see my Facebook group? I started Follow the Short Fat Bald Guy. And I've only got one guy following me for beauty tips.
I will follow you.
Hey, I am a huge fan of your Facebook posts, and that's why I want to show you off on Dental Town. I mean, so many people need to see your work. And the other thing that I also really love about you and Delia Tuttle is that when I was in school back in the 80s, dentistry was considered a man's profession.
Yes.
And now half the class is women. And they don't want to see a bunch of role models of a bunch of old, fat, bald grandpa guys. They want to see women out there crushing it. And you are a diva in dentistry, because I mean, you're only 38 years old. you could be my daughter since I'm Catholic. And my gosh, for them to see role models that are only 38 years old that are literally crushing it at the apex of the game in technology and implants and surgery and business, and I mean that you're a real inspiration and motivation, and those young girls in school need that.
I feel very honored with your words, and I was very glad within this interview and this opportunity of showing some of the work of women, and namely in surgery, because it was a man's world in a few years ago, and now even in Portugal, I think 80% of the people that are doing graduation in dentistry are women. Actually, nowadays.
Well,
it's changing, completely changing.
Can I tell you the woman that had the biggest impact on me, and bless her heart, she passed away. But in our oral surgery department, there were the two best surgeons in the world, Charlie White, Brett Ferguson, tall, 6'3", Gordon's handsome, black guys with all these big muscles. And you could tell when they were pulling wisdom teeth, you could see their triceps popping out and all this stuff. And then there was this little girl named Susan Wires who was like a year ahead of me. And she was in the oral surgery department, or 2 years ahead of me. And she didn't have all those big muscles. And she would take out all the teeth faster, and you didn't see any triceps flexing out of her arm. And she would always tell me, Howard, it's not muscle, it's leverage. You don't need to be holding the jaw under your chin and putting it in your bicep and cranking and shaking. You don't need any of that. So I would watch two huge men, and then I'd watch this little girl, and it was so amazing to watch Susan work. And whenever I had the chance, I would always watch her. So she was for my first diva in dentistry.
No, I think sometimes you have to be delicate, because sometimes it's not force, it's like delicacy. And if you put the right instrument in the right place, you don't have to be very using the force.
Yeah, I was in Asia, and it was so amazing to watch little female dentists that could not have weighed 100 pounds. And they were taking out, they were doing their wisdom teeth, full bonies. They weren't blinking, and you just realize, taking out teeth is not a game of muscle. It's a game of leverage, geometry, trig, technique. And but I really wish you would build us. Will you build us an online CE course, you think?
Yes, I think so.
Because I do cringe, and I do get emails and letters saying, how come, all the courses are always, if it's dentistry, it's a boy, and if it's a girl, it's not a dentist. It's a hygienist, it's a consultant, it's a deal. And I say, look, women dentists that create online CE courses, I call them unicorns. I mean, they're rare that will actually create the content. So I'm begging. I would love a course from you.
For me, it will be a great opportunity of showing my work, and because everyone is always learning. When we are teaching, we are learning. So I think it's a wonderful opportunity to share.
Well, again, your Facebook page is Follow the Red. Delia Tuttles is Follow the Pink. Who's Follow the White?
Marvarit Keshvari. She's now in Argentina, but she's from Iran, and she lived in Portugal for many years, and probably she's returning to Portugal this year again.
Well, email her and CC me, Howard at Dentaltown, and maybe we'll release hers after yours. Maybe we'll interview her.
Yeah, nice.
Go back to back. So Delia Tuttle, Follow the Pink. You're Raquel Zita Gomes, Follow the Red, and say the third lady's name.
Marvarit Keshvari, Follow the White.
And then I am Follow the Short Fat Bald Guy. Raquel, thank you so much for being on my show today. It was an absolute honor. It's 4 p.m. here. It's 4 p.m. in Phoenix. What time is it in Lisbon, Portugal?
Here.
It's midnight. Well, thank you so much. Thank you so much for staying up for midnight for my show. I hope you go straight to bed and have a good night's sleep.
Yeah, it was a tiring day, but it was a wonderful conversation. I really glad to be interviewed by you because you are a legend, and I'm very, very happy with that. And namaste.
Namaste. Have a great day. Bye-bye.